مساء الخير عليكم جميعا. المايك شغال. First, I would like to welcome you all, especially our guests, and thank you, Dr. Musbah, for the great efforts done to organize this meeting. And as a complementary part to the previous two lectures, I'm going to talk about medical pitfalls of bariatric surgery. Of course, I'm not going to talk about the surgical pitfalls, fistulas, reoperation, esophageal regurgitation, etc. This is not the part. But I'm going to stress the medical pitfalls of bariatric surgery. This is my disclosure. And just to remind myself and you of the different types of bariatric surgeries, the adjustable gastric banding, this is the oldest and the weakest nowadays. The Roux-en-Y gastric bypass, the duodenal switch, biliopancreatic diversion with or without duodenal switch, and lastly, and the most common now, is the vertical sleeve gastrectomy, which is the most commonly practiced bariatric surgery nowadays. Some figures from previous research: about 2 million adults underwent bariatric surgery in the United States from 1993 to 2016. At baseline, characteristics were the mean age was around 44 years. Females are the majority, 80% are females, and 70% are white, and more than 70% are insured. In 1998 complications and the mortality rate, الcomplications كانت حوالي 12%, and the mortality rate was almost 1%. This decreased complications came down to 1.4%, and the mortality to 0.04%, is the same like appendectomy or cholecystectomy. It is very safe nowadays. However, the utilization did not increase too much. It reached the maximum in 2024, 2004 يعني, and remained low at the same rate in 2016. Among the medical pitfalls, I'm going to stress 4 main points: alcohol and substance abuse, suicidal tendency, hypoglycemia, and lastly, bone health. Research showed that there is an increase in substance and alcohol abuse after bariatric surgery. And the mechanism is very simple. It is a switch of addiction. Instead of addicting food, they are reverting or switching the addiction to substance and alcohol, because dopamine and ghrelin are pleasure hormones. And if we lose them, and GLP-1 and GIP are increased, these are not the best psychological status. And probably this is a good topic for research. Now we are using the GLP-1 analogs and too much, and probably it may be good to look at this point. If there is a combination or association between psychiatric manifestations and the use of GLP-1 receptor agonists, and the protocol is ready. If any of our young researchers is interested, I can pass him the protocol. With alcohol, there is a special situation. In the Western world, social drinking is common, and when you do bariatric surgery with removal of the pylorus, then the gastric emptying is very fast, and the pharmacokinetics of alcohol are changed. It reaches the high level in a short time, then somebody who is socially drinking will need another glass and another glass and another glass, and this will lead to alcohol abuse. So if your patient is socially drinking, try to choose a bariatric surgery with preservation of the pylorus. The second is the suicidal tendency, and again, it is assumed after bariatric surgery, the psychosocial status is much better. The one who loses weight becomes more involved in social activities, and supposedly the psychosocial status is improving. But actually, there is an increased suicidal tendency in this group. And this is proved by many studies. About 17 suicidal attempts per 1,000 patients, and completed attempts 2.7 per 1,000 patients, completed attempts. Is this suicidal tendency is due to the baseline mental status of these patients? Because they say that the person who goes for bariatric surgery may have some sort of mental stress. And this is true. Because the mental stress and mental illness is more common in people searching for bariatric surgery, and even drug and alcohol abuse is more common among this group of patients. But this does not interpret everything. It does not interpret everything, because hospitalization for the same group is increased after bariatric surgery, and if you compare those who are having baseline mental illness compared to the normal, again, there is an increased mental illness and suicidal attempts after basal metabolic surgery. And in fact, the baseline mental status interprets only 50% of the suicidal tendency in this group of people. So what are the mechanisms increasing the suicidal attempts in this group of people? First, the unrealistic expectation. The lady who is expecting to be back to the college days, she will not find her expectation, and this is a source for depression. There is an increased consumption of alcohol and substance after bariatric surgery, and even those with mental illness taking psychotropic medications after alteration of the anatomy of the gut, the pharmacokinetics of the psychotropic medications is disturbed, and this again predisposes to suicidal attempts. Even the hormonal changes may be responsible. And last but not least, relationship destabilization. If a couple, they are used to each other in this way, so after bariatric surgery from this side or that side, the other partner may not be satisfied with the new situation. So what to do? You have to explain in full the whole expectation for the patient, to avoid unrealistic expectation. You have to avoid to evaluate the patient psychologically before surgery. You have to revise all the psychotropic medications. And last but not least, you have to involve both partners in all the procedure of surgery. Wife and husband, they should be involved in the decision and in the perioperative arrangement. The third, post-bariatric surgery hypoglycemia. And hypoglycemia, just to cut it short, may be one of two types. Either reactive hypoglycemia induced by food intake, or sometimes spontaneous severe hypoglycemia. And the mechanisms are so many. Changes in the gut and the rapid gastric emptying and the increased insulin level in the postprandial state, all predisposed to hyperinsulinemia and postprandial hypoglycemia, something like the dumping syndrome. But what is more disturbing is the spontaneous hypoglycemia, which is actually induced by what we call beta cell or pancreatic nesidioblastosis, due to expansion of the beta cells. And in fact, the treatment of this condition is very difficult because you may need intragastric continuous tube feeding, you may need to do pancreatectomy, and you may need to go for reversal of the bariatric procedure, which may not be easy or may not be feasible in all types of bariatric surgery. How to treat? The most important is to monitor the patient to avoid the development of hypoglycemia. And if he develops hypoglycemia, the first priority is to correct hypoglycemia to maintain the safety of the patient. Then you go for nutritional modifications, small low carbohydrate meals, and then you may use pharmacotherapy, which may contain acarbose, which delays carbohydrate absorption, diazoxide, verapamil, octreotide, all are postponing or opposing hypoglycemia. And the last measure is to go for surgical therapy, which may include tube feeding, gastric tube feeding, or outlet restoration, or reversal of surgery. Last is the effect on metabolic on bone, metabolic surgery on bone, and in fact, all studies showed that there is a negative effect of bariatric surgery on bone health, and this is shown by the changes in the bone turnover markers and in the bone mineral density. And actually, it starts very early. Bone markers abnormalities start very early, 10 days after surgery, and they continue for a long time, even after stabilization of weight. While the decreased bone mineral density is observed in about 10% of patients at multiple sites, and it starts by 6 months and continues for a long time. Do these changes in bone health, they predispose to bone injuries, fractures? Yes, and this is shown by studies. There is a possibility of fracture, and the possible mechanisms to fractures after bariatric surgery includes the effect of weight loss. The mechanical loading is the best stimulus for bone formation. So when somebody loses weight, the mechanical loading is lost, and this decreases the activity of osteoblasts and increase the osteoporosis. Nutritional deficiency, including vitamin D, calcium, and probably secondary hyperparathyroidism, and other hormonal changes may contribute to the changes in bone mineral density, and also the increased physical activity. The patient who was not moving starts now to move and play and travel, and this may increase the possibility of falling and injuries and fractures. What to do? We have to maintain vitamin D and calcium, and you encourage weight-bearing exercise to encourage the bone formation. And routinely, you have to do lab examination every 6 months for the first 2 years, and then yearly after that. This lab examination should include vitamin D level, calcium, parathyroid hormone, and albumin. Some people, they advise to do DEXA every 2 years, but this is not agreed upon. This is controversial. After all these medical pitfalls, do these medical pitfalls outweigh the benefits of bariatric surgery? And the answer is no, absolutely. Because all the studies showed that there is a benefit from weight loss shown in diabetes remission, and this was shown even whether the body mass index is above 35 or below 35, all patients benefited from bariatric surgery, and diabetes remission was higher. And even the survival studies, the mortality and survival improved from 29 to 29% to even 89%. Lastly, when we talk about anything now, we have to mention something about COVID. And comparing COVID in patients who underwent bariatric surgery, the positive cases were equal. However, in those who underwent bariatric surgery or the control group, but the severity of cases, the need for hospitalization, the need for oxygen supplementation were less in the bariatric surgery group. To summarize, non-surgical pitfalls. Just show the last. Non-surgical pitfalls of bariatric metabolic surgery include, among others, substance abuse, suicidal tendency, decreased bone mineral density, hypoglycemia, and probably perioperative DKA. Benefits of bariatric metabolic surgery outweigh the potential risk. Careful selection, team management, and standard follow-up programs are mandatory to ensure the benefits of bariatric surgery. Thank you.